Okay, I think there will still be some people joining as we're going ahead, but I think just so that we stay on time, I think we will start. I apologise for my poor camera quality. I look like I'm standing at the back of a very large room, but I'm actually very close to the camera. We've just lost our remote control. And about 5 of us have tried to figure out how to do it manually. We're epidemiologists, not AV people, so. So we'll get started. Thank you everyone for attending today. I'm Abby Diaz. I'm an early career researcher at Menzies School of Health Research and the Vice President of the AEA. I'm very honoured to chair today's symposium, and I'm looking forward to hearing from each of the speakers. They have each made important contributions towards improving the collection and reporting of race and ethnicity data in Australian health data sets. As you'll no doubt hear today, collecting this data is important to make the invisible visible, so to speak, and this is often not straightforward with multiple points and various users along the information pipeline. Today, we're lucky to hear from multiple different viewpoints and experiences. Before we get to the talks, I'd like to acknowledge the Aboriginal and Torres Strait Islander people of the lands and seas of this country that is now known as Australia. As this is a virtual event with people logging in from around the country, I want to urge you all to take a moment to think about whose land it is you're on today. Today, I'm on Turrbal and Yagara land, and they are the sovereign people of these lands to the north and the south of Brisbane, Meanjin, and I pay my respects to their elders, past, present, and I acknowledge that this was and always will be Aboriginal land. I also want to acknowledge and welcome all Aboriginal and Torres Strait Islander people presenting and attending this virtual event today, as well as any people speaking and presenting here from culturally and linguistically diverse populations. So just a few housekeeping things before we get going. Can everyone, except for whoever is the speaker at the time, put yourself on mute, including the other speakers who aren't speaking at that point in time. So first of all, questions. We have a question and answer session at the end, so use the chat function to type your questions in. Please keep the chat window just for questions so that they don't get lost amongst other chatter. Keep your, sorry, I can hear my feedback from another room, so it's distracting me. Can everyone please keep their questions succinct as possible, and if you want to direct it to a particular speaker, please indicate who that is, and if you want us to say who is asking the question, please put your name and where you're from. So keep your microphone on muted. It might also be less distracting if we turn off our cameras. There's a picture on the side that shows how you can just change it so you have only the speaker video showing as well as the shared screen. So that's the little along the top of the panel that has all the videos. The second square is the show the active speaker video. If you want to, that might make it easier to follow along. And this event will be recorded and available to AEA members, and a link will be sent in an upcoming bulletin, so members will be able to view the recording. All right, well, without further ado, I'd like to continue on to our presentations and welcome our first speaker. Professor Ian Ring, who has been awarded an Order of Australia for his research, is currently in the Division of Tropical Health and Medicine at James Cook University. Previously, he was the head of School of Public Health and Tropical Medicine at JCU. He's the principal medical epidemiologist and executive director of the Health Information Branch at Queensland Health and the foundation director of the Australian Primary Healthcare Research Institute at the Australian National University. He is an honorary professorial fellow at Wollongong University and adjunct professor, School of Public Health and Community Medicine, University of New South Wales, an expert advisor to the Close the Gap Steering Committee and member of the International Indigenous Health Measurement Group. as well as the Aboriginal and Torres Strait Islander Demographic Statistics Expert Advisory Group for the ABS, the AOHW Indigenous Statistical and Information Advisory Group, the Australian Indigenous Health Infonet Advisory Board, the AMA Task Force on Indigenous Health, and previously the RACP Aboriginal and Torres Strait Islander Health Expert Advisory Group and the National Advisory Group on Aboriginal and Torres Strait Islander Health Information and Data. And the title of Professor Wren's talk is Aboriginal and Torres Strait Islander Health Information, Progress, Pitfalls, and Progress. Progress. Thank you, Ian.
Thanks very much, Abby, and I'd like to acknowledge the traditional owners of the lands on which we meet and pay respects to the elders past and present. So I'll just go to share screen, hopefully. How's that? Is that working?
I can see that.
Okay, so in this brief talk, I just want to try and outline what's happened essentially over the last quarter century or so, and talk about progress, pitfalls, and there are some real pitfalls, and also prospects. So this is going to be a bit of a potted history of national approaches and developments. And in all of these things, identification is really central to the issues. And it touches particularly on our ability to tell whether things are getting better or not, whether you're talking about mortality or anything else. So I'm going to spend a little bit of time on backcasting and the use of the census for assessing progress. Most importantly, I want to discuss the use and particularly the lack of use and the misuse of the available information. And finally, I want to finish on some of the challenges for the future. How to improve census estimation of life expectancy, small area data, testing rates for COVID-19, measuring racism, social emotional well-being, and a focus on services. So let's start about 25 years back with what's called the Aboriginal and Torres Strait Islander Health Information Plan. And you'll notice in tiny print under it, it's called This Time, Let's Make It Happen. And I said that because over the previous, decades, we had been faffing around basically getting nowhere. So in 1994, ARMAC, which is the Health Ministers Advisory Council, or basically the heads of the state and territory and Commonwealth health departments, endorsed a recommendation to work with Aboriginal and Torres Strait Islander peoples to develop a plan to improve all aspects of information about their health and health services. And as I say, the emphasis this time was on making it happen. So the report describes the shortcomings in the current collection, processing and use of Indigenous health information. And notice that the major deficiency noted then was the poor quality of Indigenous identification in administrative data collections. And interestingly, note, there was little new in its findings or recommendations. Most have been the subject of previous reviews, and that's what Australia does. Carries out endless reviews, makes endless recommendations, and then fails to implement them. And so this report had a lot of emphasis on actually implementing the recommendations. And in order to support that process, a body with a rather sort of unique acronym, NAGATSI, the National Advisory Group on Aboriginal and Torres Strait Islander Health Information and Data, was formed with responsibility to provide advice on improving the quality and availability of data, to formulate and implement national plans, advise ABS and AIHW and other committees on performance measures, and to underpin the implementation of the NAGATSI strategic plan. And finally, and importantly, note the last dot point, that the aim was to ensure that approaches to the collection of that information are culturally respectable and, most importantly, maximise the benefit to Aboriginal and Torres Strait Islander people. Now, this group was different because it had authority. Previous efforts really, previous groups were really consisting of people who didn't have the authority to turn the recommendations into action. So this group was chaired by an ARMAC representative, that is, one of the heads of the state and territory health departments, and hence recommendations from the GATSI head could go straight to ARMAC and to the Health Ministers' Council. It had a majority of Aboriginal and Torres Strait Islander members from a wide range of sectors, and to my mind at least, and this is what it says officially here, it was a more or less unique example of a working partnership between government agencies and Aboriginal and Torres Strait Islander people. Unique internationally and to some extent unique in Australia. Now, I was on this body from the outset, and there was no occasion where the wishes of Aboriginal people were not respected and carried. So let's start then with the first NATS, the National Aboriginal and Torres Strait Islander Survey in 1994. Now, up until that time, the only thing that ABS did was to count people in the census. And Puggy Hunter at the time said, that's all you do and you can't even count the mob. And that was fair comment. ABS did not see it as part of its core responsibility to measure key aspects of Aboriginal health and social and economic circumstances. Well, this report, to some extent, changed all that in 1994. Now, the NATSIS survey came out of the Royal Commission into Deaths in Custody. It was separately funded, which is why ABS actually did it. And as you can see in the last paragraph, it covered a range of social, demographic, health and economic characteristics of the Aboriginal population, with full Aboriginal participation at all levels. Next comes the health surveys. Now, ABS had been conducting health surveys for a long period of time, but those surveys did not have a separate estimate of the Aboriginal and Torres Strait Islander population, considering this was the group with the greatest health need. This was a serious mission. At this, we had these forums where Commonwealth and state representatives got together and advised various bodies, in this case ABS, and I was representing Queensland at the time, and was able to, with others, persuade my colleagues to part fund oversampling of the Aboriginal population so that we would, for the first time, have an Indigenous sample. So that happened in 2001 and 2004, and to its great credit, ABS now carries this out every 6 years thereafter out of its own resources. It doesn't seek extra funding for that anymore. It covers all geographic areas, although there are special provisions for those in remote areas. Now, even though the Australian administration in Papua New Guinea conducted its first biomedical risk survey in 1970, yes, that's right, 1970, Australia did not carry out such a survey until 2011-13. But that survey did have an Aboriginal and Torres Strait Islander sample of around 3,300 adults who were then tested for various chronic disease and nutrient biomarkers. So that was a first, and a lot of effort went into its preparation, development and delivery. So our two national institutions have come a long way. And this is just a brief list of recent AIHW reports. Now, AIHW's counterpart in Canada has nothing like this. So this is just recent reports: health performance framework, acute rheumatic fever, Indigenous injury, primary healthcare data sets, oral health, better cardiac care, cultural safety, hearing health, aged care, disability support, community safety, education and skills, employment, housing, income and finance, Indigenous welfare and well-being, and Indigenous eye health measures. And as I say, this is just recent reports. So there's a wealth of information coming out from AIHW. I'm not saying for a moment it's all that we would like, but it is a considerable effort. There's not only effort by government agencies, but increasingly in recent times, there's research by and for Aboriginal and Torres Strait Islander people. So that the Maya Kuayu study, spearheaded, I think, by Ray Lovett, the grounding principle is that strong culture is related to good health and well-being. So this survey follows up people 16 years of age. To some extent, it's a voluntary self-selection group of people, and the aim is to ensure there's a national representation to get that detailed understanding of the relationship between culture and well-being. So what are the pitfalls? Well, they're pretty basic, some of them. You might think that you could just use successive censuses to see how life expectancy, for example, is hopefully improving. Well, I think there are real risks with that, and we're going to see some more about that in a second. I don't believe that the linked sample, this is my own personal view, between census, the pairs and deaths record is adequate, particularly for older ages. So you get large raising fractions based on very small numbers of older people. There are other issues as well. So, as I said, I think there are issues in monitoring trends by use of the census and also by use of backcasting. I want to look at that in a little more detail in a second. What we don't do nearly enough of is look at the things that would help not just to document disadvantage, but to reduce it, to monitor the needs for services. Our information on that is woefully inadequate. Evaluation is often bitty, piecemeal, ad hoc, done by external agencies. And I'm hoping very much that now that Ron Mokak has, that is part of his brief within the Productivity Commission, that will become a far more productive endeavour. Management and policy use of information, well, really, it's little more in many cases than sitting around hoping that next year's numbers will be better without actually doing anything to make sure that that's the case. COVID-19, the one thing that's really important is to know who was tested. And by and large, at a national level at least, we don't know the testing rates for Aboriginal and Torres Strait Islander people. Although, reassuringly, some early work done for New South Wales suggests that the testing rates for Aboriginal people and Torres Strait people were broadly at the same level as the rest of the population. So now looking at the census, this slide, taken from an ABS publication, shows the changes in identification between 2011 and 2016. Now, a census is simply a snapshot at a particular point of time of those people who identify as Indigenous at that point in time. So if you look at the last column, the third row down, you'll see that there are 120,000 people who identified as non-Indigenous in 2011, but who identified as Aboriginal or Torres Strait Islander in 2016. And if you look at the row above, you'll see that there's 40-odd thousand people who did the reverse, identified as Aboriginal or Torres Strait Islander in 2011 and not in 2016. So 120,000 minus 40,000, roughly 80,000 people out of estimated resident population of, say, 700,000 plus, switched identity. and between 2011 and 2016. And those newly identified people were better educated, more affluent, lived in cities and towns, and almost certainly healthier. So that any change that you pick up in life expectancy is likely to be due in whole or in part to people who switched identification between 2011 and 2016. Now, this is a graph taken from the latest health performance framework on all causes of mortality. And the point I'm addressing here is backcasting. So look at that. Well, not too bad, you might say. The top line is Indigenous Australians, all causes of mortality. And between 1996 and 2020. So you see a fairly rapid decline in mortality between 1996 and 2008. But to me, the picture is really more than somewhat implausible. It's pretty hard to see what health service social determinants, economic or political change might account for the dramatic improvements between 1998 and 2008, and then a flatlining between 1998 and 2008. And there's really a problem with backcasting, and that is the circularity. You take a population in, say, 2020, and you try and work out a consistent population over the period in which you are assessing trends. And assessing the population requires you to estimate what's happened to fertility, mortality, and maybe migration over that period. The problem is that the assumptions predetermine the outcome. If you assume mortality has fallen, when you crank the handle, that's exactly what you find. If you assume mortality hasn't gone anywhere, then when you do the analysis, that's what you find. So this is what I mean by circularity. And I think what you see here in that apparently dramatic improvement between 1996 and 2008 is really a reverse compound interest type of thing, where the further back you go, the greater the problem in that mortality assumption. If you, so just to look at use, misuse, and lack of use of information, I think there's a real issue in presenting statistical artifacts as real progress, and particularly when you're looking at trend analysis. And that's exactly, I think, what is done in the Health Performance Framework and in the Prime Minister's Closing the Gap report, particularly in looking at these magical gains between 1998 and 2008. The second issue is a belief that all you need do to bring about change is publish reports of indicators, that these reports of themselves will stimulate action. Well, I've got decades of experience that says that isn't true. As I said earlier, we haven't got the information on the inputs for change, on funding and services. Blind external evaluation rather than continuous quality improvement is counterproductive. We don't have the formal management processes that you see in all other lines of activity, where people running some kind of activity, whether it's economic or a business or whatever, they want to see how well they're doing. So they have a formal look at how well they're doing every month or every 6 months or annually. We don't do that. We simply hope it will be better. That really has to change. In terms of prospects for the future, I think we can use the VII for working out, giving us a better idea of who's Aboriginal in the linked sample using the Census for Life Expectancy. We really have to stop backcasting for 20 years. The ABS in this report I've given you the link to here says we should limit backcasting to 10 years, and I agree absolutely. I think it is safe to backcast for 10 years, and I think it's unsafe to extend it beyond that. We need to ensure that identifiers are on private path lab request forms. We need to be working towards provision of community level data rather than simply national, state or regional data. We need measures of wellbeing, culture and racism, and I'd like to commend the work of Gail Garvey, who's really taken this a considerable step forward. Management use of information is really a key thing. Information unused does not bring about change. Information needs to be seen not as something that stands alone, but is part of a continuous policy cycle, as shown here in this WHO diagram. You establish in action 1 what you would like to do. You assess the situation on the ground. You look at how much money you might be able to bring to bear, to use to bring about change. You look at the constraints, you develop strategies for change, then you implement it. And then finally, and most importantly, you use information on monitoring and evaluation to see how you can and should do it better. And that feeds into a continuous policy circle. So that's all I wish to say. I hope I've stuck more or less to time, and I thank you for your interest.
Thank you, Ian. That was a very insightful and interesting presentation. I'd now like to welcome our next speakers. Dr. Mandy Trong is a research fellow at the School of Nursing and Midwifery at Monash University and Senior Project Officer at Menzies School of Health Research. Her primary research interests centre on examining and addressing the social determinants of health in relation to racism, discrimination and gender inequality. Also, Mandy will be presenting with Dr. Jocelyn Chan, who is an epidemiologist and PhD candidate at the Centre of International Child Health at the Murdoch Children's Research Institute. Jocelyn's research aims to understand how many people are needed to receive the pneumococcal vaccine in order to achieve herd immunity in low and middle income countries. Dr. Trong and Dr. Chan recently published with MJA on the topic of this talk they're giving today on diversity and this COVID-19 vaccine rollout. We can't fix what we can't see. Thank you, Mandy and Jocelyn.
Sorry, I had to unmute myself. Thank you very much, Abby and the AEA for having us at this symposium today. I wish to acknowledge that I'm on the unceded lands of the Wurundjeri people, and I pay my respects to the owners of the land on which I live and work. I also pay my respects to elders past and present and all Aboriginal and Torres Strait Islander people at this symposium today. We also stand in solidarity with all Aboriginal and Torres Strait Islander people on this 30th anniversary of the Royal Commission into Aboriginal Deaths in Custody. So as Abby mentioned, this presentation is largely based on an article that we published recently and which drew attention to the lack of COVID-19 data related to racial, ethnic and linguistic background in Australia, which is really indicative of the larger systemic health data gap that exists here, which really limits our ability to identify, report and monitor health disparities among racial and ethnic minority communities. The COVID-19 global health crisis, as we all know, shone a huge spotlight on the existing health, social and economic inequities experienced by marginalised individuals and communities across the world. In the early months of 2020, when the COVID pandemic was spreading across the world, there were concerns among many of us that individuals and communities from racial and ethnic minority backgrounds in countries such as Australia, England and the US were at risk of suffering disproportionate impacts from the pandemic. The existence of racial and ethnic health disparities in these countries is already well established, and these disparities are the result of historical and ongoing structural racism, colonialism, violence and intergenerational trauma. Racism is a root cause of health disparities. It's associated with poor mental and physical health and more negative patient experiences of health services. However, particularly in the early stages of the pandemic, there was little publicly available data around the world about the racial and ethnic makeup of individuals who had acquired COVID-19, who had been hospitalised with COVID and who had died from COVID. As the racial data gradually became available internationally, it became quite clear that particular racial and ethnic minority groups were the hardest hit by COVID. And it was not only patients, but healthcare workers as well. For example, in the United States, as of September 2020, there were 213 registered nurses that had died of COVID, of which almost 60% were nurses of colour. And more than half of these nurses of colour who had died to date had been Filipino. But Filipino nurses make up only about 4% of registered nurses across the entire country. In the United States, the tracking of COVID racial data was left to non-government organisations, including news organisation The Atlantic, with some researchers, a large number of volunteers, and community and philanthropic donations. Despite this mammoth effort, the COVID racial data tracker has many limitations, including lack of consistency in how states defined, published, and presented COVID-19 data. And there was little guidance from their federal government on how to direct states on how to compile and present this COVID racial data. And this was exacerbated by the extreme fragmentation of American public health infrastructure. Furthermore, COVID-19 data had become highly politicized in some instances. For example, you may have heard the stories and the reports about the data scientist in Florida who had built Florida's COVID-19 tracking dashboard, was fired and then subsequently arrested after she accused the Florida Health Department of pressuring her to hide COVID-19 data in order to justify reopening their state. Well, fortunately, things have turned around somewhat with the election of the new federal government earlier this year. So what we do know is that in the US, which really is only based on 53% of case reports that have actual race and ethnicity data available, is that African Americans and Latinx Americans are around 3 times as likely to be hospitalized and twice as likely to die compared to non-Hispanic whites. American Indian and Alaska Natives fare even worse. Thankfully in Australia, Aboriginal and Torres Strait Islander people fared much better with low rates of infection compared with non-Indigenous Australians. If we look across to the UK, based on a sample of about 17.5 million adults, these researchers found that South Asian, Black and mixed ethnic groups were more likely to test positive for COVID than whites, and the risk of mortality was estimated to be between 25 and 56% higher in ethnic minority groups compared with white adults. Unfortunately, we don't know what the situation is for non-Indigenous racial and ethnic minority communities in Australia because we don't have the data. Sometimes racial data tells us something we don't know, but other times we need this racial data to confirm something that we already seem to know. However, even though we don't have racial data regularly and accurately collected in Australia, and same for some other jurisdictions, we can hypothesize that racial and ethnic disparities are likely to exist in this situation and that they are very strongly linked to the social determinants of health, including structural racism, housing density and insecurity, being essential workers, and a greater reliance on public transport. In addition, many minority groups are disproportionately affected by chronic medical conditions, less access to quality healthcare, higher levels of insecure work, and more crowded living conditions. Furthermore, some communities experience more difficulty accessing timely health information in a form that they can understand. They might be more exposed to misleading rumours and confusing messages about coronavirus and vaccinations. A refugee health nurse in Victoria expressed to me that there were real concerns out there among some refugee and migrant communities about COVID vaccinations, and that they were working really, really hard to provide these refugee and migrant communities with timely and appropriate information that is delivered by trusted community members. So now I'll pass over to Jocelyn, who will speak in more detail about the Australian context.
Thanks so much, Mandy. And I'd also like to acknowledge that I'm on the unceded lands of the Wurundjeri people, and I pay my respects to elders past and present, as well as to all the Aboriginal and Torres Strait Islander people at this symposium today. And of relevance to our topic, I'd also like to acknowledge all the Aboriginal scholars who have shaped the way I think and understand race and racism in Australia. So in this section, I will talk about the availability of cultural, ethnic and linguistic data in our routine COVID and COVID vaccine monitoring in Australia. So the main way we surveil COVID is through the National Notifiable Diseases Surveillance System. This is the system that provides the numbers that I and many Victorians used to wake up and check every morning of the second wave. And it's for a range of communicable diseases, not just COVID. Just a quick disclaimer that I'm not currently involved with the COVID response, and things are rapidly changing all of the time. And I have great respect for our epidemiology colleagues who are driving a lot of these changes. So I'd love to hear from you, from your direct experiences as well. So this diagram describes the data flow. And starting from the bottom, when somebody develops COVID-19, they will hopefully go to see a doctor who will arrange a lab test. And if positive, the doctor will then notify the public health unit. For some diseases and for negative tests, we are primarily reliant on laboratory notifications. And this is something our previous speaker has touched on. Typically for laboratory notifications, we don't get a lot of information, just the contact details of the patient and possibly why the test was ordered, but certainly no called data. Which means we're not able to examine inequities in COVID testing using this system. Once a case is notified to the public health unit, public health officers will conduct a detailed interview with the patient, and this is typically where the called data is collected. But it has been previously quite variable by state. So at October last year, 6 out of 8 jurisdictions collected country of birth, 7 out of 8 collected language spoken at home, and 3 out of 8 collected ethnicity data. Although there are recent changes in which country and birth and language will be collected by all jurisdictions. And certainly previously called data collected at the state level was not reported up to the national level, and this is also changing. While comprehensive data is not publicly available, we do have some evidence of health inequities. And this was provided to the Contact Tracing Inquiry in Victoria by Jerome Weimer, who was a representative of the Department of Health. He said 50% of the people who have contracted COVID in Victoria were born outside of Australia. And that is significantly more than the proportion they are of the population. So vaccination offers us an opportunity to protect those at greatest risk and achieve health equity, but can also exacerbate these health inequities if the vaccine itself is distributed inequitably. So in the United States, vaccine coverage among Black and Hispanic people in the lighter blue have been consistently lower than white and Asian people. This may be related to vaccine confidence and communication to these groups, but also we need to consider access to vaccines. Where are the clinics located and how easy are they to book appointments? But also at a policy level, decisions like whether essential workers are prioritised for vaccination will impact on coverage rates among racial and ethnic groups who are overrepresented as essential workers. Again, in Australia, we have historically had limited cultural, ethnic or linguistic diversity data about immunisation coverage. So starting again from the bottom, the majority of our vaccines are given either by GPs or in dedicated vaccination clinics. And many of these clinics have software which will link directly to the Australian Immunisation Register. However, it is also possible for registered vaccination providers to directly enter vaccinations via an online portal. And individual GPs may collect call data on their patients, but until recently, this was not reported to the Australian Immunisation Register. And the availability of this register to provide comprehensive coverage data is something that we should be really proud about, but collecting this additional call data will help us to ensure equity. And again, from my understanding from news reports is that this data will be collected for COVID, but I don't know the details of how exactly this is going to work. Since there was previously no called data available, researchers who have wanted to examine potential disparities in vaccination uptake have undertaken data linkage studies. So this particular study linked immunization data with state-based birth, perinatal and hospitalization data, which does have some called data, called information. And they found that overall childhood vaccination with diphtheria, tetanus and pertussis vaccine was high, but lower in the children of mothers from Oceania and North America compared to children of Australian-born mothers. It's really unclear how this applies to COVID vaccines, which are so different and target a very different age group. And importantly, this data linkage process involved 9 approval and regulatory bodies and took more than 2 years to assemble. So it's really not suitable or timely enough to inform responsive vaccination strategies for a pandemic like COVID. I also want to briefly talk about some of the practical considerations for collecting this data. Firstly, which variables should we be collecting to understand cultural, ethnic and linguistic diversity? The government has currently committed to collecting country of birth and language data as part of the NNDSS and for the vaccine rollout, but this would fail to measure health outcomes in second and subsequent generation migrants. Identification of ethnicity can be challenging, and Mandy has a great example of this. She was involved in some work conducting a survey among school children, and while children of Chinese or Vietnamese heritage, for example, were very easily able to answer the question about their ethnicity, many white children have never had to consider their own ethnicity or talk about it with their parents and really struggled to answer this question. And this shows up in our census data. 33.5% of people responded to the census reporting that their ancestry was Australian, but it's really difficult to interpret exactly what this means. And related to this, we live in a multicultural society and many people will have multiple ethnicities, so how best should we capture this? Lastly, frontline workers and public health officers are busy, and asking about ethnicity can feel uncomfortable for some people. So how do we ensure that this data is comprehensively collected? Aside from the practical concerns, there are social and ethical implications of collecting this data. Understandably, there may be issues related to trust. People may be wary about providing this personal information and how exactly it will be used. Importantly, there needs to be separation between data collected for health reasons and other government functions to avoid the risk that it might be used for immigration control, for example, as this may deter health seeking. There is also a risk of stigmatizing certain ethnic groups if this data were to be made public. But I've included this image on the right to point out that the absence of data has not prevented stigmatizing commentary in the media thus far. This column is entitled "Mass Immigration Left Victoria Weak to Virus," and the Australian Press Council has described it as offensive and prejudicial to those who are from diverse backgrounds, and I would agree. Lastly, there's perhaps a more subtle risk to collecting called data, that we may become a bit fatalistic to the health outcomes that we see in certain population and accept that it's somehow an inherent flaw or characteristic of this group of people, which can get in the way of achieving health equity. So to conclude, I'd just like to say that data is central to advancing health equity, but I think I'm speaking to the converted in this situation, as epidemiologists, we're all pretty big fans of data. But just to point out that it's really useful in identifying health inequities, both in COVID-19 outcomes and in the vaccination rollout. It's useful for guiding resource and effort allocation. It's important for identifying best practices, and the success of the Aboriginal and Torres Strait Islander-led response to the COVID-19 is a great example of this, and also for measuring progress towards equity. But we do need to consider interpretation of this data and the implications. Thank you very much.
Thank you very much, Jocelyn and Mandy. That was a fantastic and informative presentation. We now have another joint presentation by Associate Professor Lisa Wapp and Dr. Tamara Butler. Associate Professor Lisa Wapp is a Senior Research Fellow at the National Centre for Epidemiology and Population Health at the Australian National University, and she is a Torres Strait Islander epidemiologist. She leads a program of work dedicated to eliminating cervical cancer among Aboriginal and Torres Strait Islander women. Lisa's also told me that they're planning a fire drill in her office today, so if she does need to leave, then we'll just skip on to the next speaker and she can come back when she can. Also, Dr. Tamara Butler will join Lisa. Tamara is a postdoctoral researcher fellow at the Menzies School of Health Research, recently awarded a Discover Australia Aboriginal and Torres Strait Islander Award from the Australian Research Council for her work in HPV. She is an Aboriginal early career researcher with a research vision to improve gynecological cancer outcomes for Aboriginal and Torres Strait Islander women. The talk from Lisa and Tamara today is entitled "The Global Effort to Eliminate Cervical Cancer. What does the data tell us about Australia?" And thank you very much, Lisa and Tamara. You're just on mute, sorry, Lisa.
Hi, Abby, can you hear me now?
Yes.
Great, sorry. I'm just had to escape my office because of the fire drill, and I then locked myself out of the office. I'm sitting outside in very cold Canberra, well, at least for this Queenslander. So I hope you can hear me. And so I will start our presentation today. Thanks for that great introduction, and thank you for the AEA and Menzies for having us today. I also want to start by acknowledging the unceded lands that I'm on today here in Canberra, the Ngunnawal Ngambri country, and also pay my respects to where Tamara is sitting today. They're on Turrbal Yagara country in Meanjin, Brisbane. And I'm a descendant of the Gumagal people of Mubiag Island in the western part of the Torres Strait, and Tamara's family connections are to the Ndumbi tribe on Sunshine Coast. And together we also want to pay acknowledgement to the families who today would be a very difficult day for them, excuse me, as today marks 30 years since the Royal Commission into Aboriginal Deaths in Custody. So our talk today, as Abby alluded to, is on the global efforts to eliminate cervical cancer, and really thinking through how data, what data tells us and what it hasn't told us, and really how it's been a major obstacle in the fight and the race to elimination. So what we do know is that cervical cancer is preventable, and many of you would know this, but just to recap, we know that we can prevent cervical cancer through vaccination against human papillomavirus, through regular cervical screening with a high performance test, and treatment of pre-invasive disease. In Australia, we're very lucky to have a national program of HPV vaccination via a school-based immunisation program for adolescents in Year 7. And we now use a non-valent vaccine 6 months apart, 2 doses 6 months apart. We also have the National Cervical Screening Program, which has operated since 1991, which was previously a 2-yearly pap smear looking for abnormal cells. And now we have switched since 2017 to a 5-yearly HPV test with the option of a self-collection for women who are over the age of 30 and overdue. So I guess the real crux of this is that cervical cancer is curable if detected early and treated accurately. In 2018, the Director General of the WHO called for a global action towards supporting what really excitingly could be the elimination of the first cancer. In 2020, we launched the global strategy to accelerate the elimination of cervical cancer as a public health problem, and identified three goals that we must be on target by 2030 to reach, commonly referred to as sort of 90-70-90 goals. Elimination has been set at 4 per 100,000 women. So not that there will be no cases of cervical cancer, but there would be very low numbers of cervical cancer. And so those goals are about reaching 90% of girls vaccinated with HPV vaccine by the age of 15, 70% of women screened by 35 years, and then again by 45 years with a high performance test, such as a HPV test that we have in Australia. And then 90% of women treated with pre-cancer for pre-cancer disease, or 90% of women with invasive cancer treated.
Thanks, Lisa. Okay, so I guess, yeah, Tamara here. Australia actually is a global leader in cervical cancer elimination. We are predicted to reach that threshold of elimination as a public health problem by as soon as 2028. So we're moving along pretty well with this. Our incidence is about 6.3 per 100,000 women. So we need to reduce that incidence by 37% in order to reach that elimination target. And our mortality is 1.4 per 100,000 women. So, you know, a lot to be proud of there. We've made lots of progress. And just to put that in a global context, this plots some of the data from world areas from GloboCan 2020. And so you can see we're down here on the right-hand side, having one of the lowest incidence of cervical cancer around the world, which is really great to see. But of course, we're here to talk about health inequities. And so I guess the major thing we wanted to bring to your attention is that this data masks significant within-country inequities in cervical cancer outcomes. So focusing in on Australia, Aboriginal and Torres Strait Islander women experience a greater burden of cervical cancer compared to non-Indigenous women. We have a high incidence, twice as high as non-Indigenous women, and mortality is more than 3 times higher. And this inequity is shared across global Indigenous populations. So there's significant inequity, both in incidence mortality and also in terms of that complete data. There's a lot of incomplete data registers out there. So just to show you that same graph and put it all in context, here we've actually plotted some data from a paper we recently published that produces a report card for 4 high-income countries, Australia, New Zealand, the US and Canada, on how they're performing on those key World Health Organization elimination targets nationally and for Indigenous women within those countries. And using these data, we can take a closer look at with that within country inequity that I mentioned. Before I dive in though, I'll just mention here that the incidence rates here are a little bit different from the ones that you'll see reported commonly because we've recalculated those incidence rates using the World Health Organization recommended method. So the rates will differ a little bit, but gives you the lay of the land anyway. So yeah, diving in, you can see here's Australia and New Zealand as a world area. And then for Aboriginal and Torres Strait Islander women and for Maori women, you can see that the rates there are, you know, more than twice as high. And this really puts us within the context of other developing countries and countries that don't have the incredible screening programs and vaccination programs, organised programs that have been in place for decades. That really puts us among that company. So that's really strong inequity that we're seeing there. You know, and there's also Northern America. So for Canada and the US, those countries, here we really have a lot of question marks over what that data looks like. So for Canadian populations, there's been estimates to say it's maybe twice as high, the incidence, compared to non-Indigenous women in that country. But the reporting there is not complete enough to be able to report clearly on that. And yeah, among Native American and Native Alaskan women, there's been reports that it's a little bit lower, but again, we know that there's a lot of issues with the data registries in those countries. So there's a lot of within country inequity in the incidence there. And just looking briefly at the mortality and just focusing on Australia, you can see that we're right down here with a very low mortality of cervical cancer, but for Aboriginal and Torres Strait Islander women, it's almost 3 times as high, 3 times as high. So yeah, we've got a lot of work to do to ensure that this push for elimination includes all Australian women.
Thanks, Tamara. So I'm just going to do a little bit, I guess, like what Ian did and talk through a bit of a timeline of some key data events by the 2 national programs. So if we look at HPV vaccination, we saw, as I said earlier, that we saw the introduction of the world first school-based immunisation in the world here in Australia, offering girls the vaccine and then up to a catch-up of the age of 26 for girls. We knew that Indigenous status was collected, but it was via a consent form, and that's operated under National HPV Register at the time. However, up until 2013, we had no reports of HPV coverage or initiation by Aboriginal and Torres Strait Islander status until 2013. In that same year, we moved to a gender neutral approach, vaccinating both boys and girls. So that first report by Julia Brotherton and co-authors reported only for 2 jurisdictions, so both Queensland and for the Territory, Northern Territory, and it really documented some interesting and important public health findings. So in Queensland, coverage among Indigenous girls compared with non-Indigenous girls was lower with each dose, so about 4% for dose 1, 10% for dose 2, and 15% for dose 3. But the pattern was quite different in the Territory, where initial uptake of dose 1 was 17% lower. But for those Indigenous girls that did start dose 1, they completed through just as much as any other person to dose 3. So that was when we had the 3-dose vaccine schedule with the quadrivalent vaccine. In 2018, we moved to a non-valent vaccination. So we're now vaccinating both boys and girls, and we're vaccinating with only 2 doses 6 months apart. And in that year, the National HPV Register also ceased to operate, and all HPV data is now recorded to the Australian Immunisation Register as it shifted to the Whole of Life Register. This is sort of a really important move, I suppose, because what happened was there was a real concerted effort from the National HPV Program to work on improving Indigenous status via the collection consent forms. And they had done a lot of work in this space, which I'll show you on the next slide. But of course, that changed when it moved to the Australian Immunisation Register. In 2019, Julia, myself and other colleagues published the second report. So, almost a decade or so after, around Indigenous status for HPV vaccination in 4 jurisdictions. In 2021, in Australia's first cervical cancer elimination report, we were able to report HPV vaccination initiation by ages 15 years for all states and territories by Indigenous status. So a really remarkable improvement in a relatively short amount of time, but still obviously it would have been fantastic to have that in the very beginning. And I suppose now that it's moved to a different register, it also uses a different denominator, and therefore we can't compare the rates that are currently reported to those that were previously reported in the National HPV Program. So this slide was just to really demonstrate in the older program, in the quadrivalent vaccination program, the real concerted efforts of the program to document Indigenous status. So if you just focus on the green, that's the Indigenous status that was unknown, that was previously sent back to the register. And you can see over time that sort of was about 50%. And in the final year in 2017, that was as small as 8% unknown. So a lot of work. In the next slide, this is just basically demonstrating the HPV vaccination coverage completion by age 15 years by Indigenous status. This is in the new report, so we can't compare to the old numbers. And it does show, because we moved different denominators, that it's a little bit lower than what we previously had reported. So previously we thought in Australia that we were reaching the 80% target for girls, but actually shows that there's a little bit more work to be done. So if we move to looking at screening, it's actually a considerably different approach. So as we know, in 1991, the National Cervical Screening Program was introduced. That was a 2-yearly pap smear program, and that's been running ever since. All states and territories established a pap test register to record those results. And while some of those registers did include a variable for Indigenous status, because the pathology report forms are the main data source for the registers and they don't collect Indigenous status, those were highly incomplete data. And that's really been the main story in cervical screening ever since. So so that's just to be clear, is that's the pathology report forms continue, and still today, to inform the Indigenous status for the pathology report forms, but because it's not calculated or collected, we don't really know much from pathology. So in 2002, and then again in 2006, we had some sort of the first reports, which was by researchers Michael Curry and co in Queensland, and then John Condon and Philippa Binns in the Territory, which really documented stark inequities in participation for Aboriginal women, showing that they were really not, the program was not meeting their needs and about half the participation rate to that nationally. And then in 2013, the Australian Institute of Health and Welfare did a business case about the inclusion of Indigenous status on pathology request forms. This is a long-standing issue. Many people here would know and have done work on that. And just to say that these timelines are in no way comprehensive, it's just a bit of a snapshot given our time today. So the AHW business report, business case really identified two main recommendations about how to overcome and include pathology report forms to have Indigenous status, which was seen as a really clear and beneficial thing to do, given that it wasn't just about cervical screening, but other communicable diseases. In that same year, John Condon led the National Indigenous Cervical Screening Project through the NHMRC with many people, some of you who would be on the line, where we linked multiple data sets. So you can kind of see this real interwoven approach of research answering what public health programs failed to do. So if we move on, so in 2016, we published the first population-based estimates around cervical screening for Aboriginal and Torres Strait Islander women in Queensland. And we were able to see that again, that participation was lower for Aboriginal and Torres Strait Islander women, but there had been no improvement over time. So this is almost 25 years post the implementation of the National Cancer Screening Program. And we go on, and I won't go into detail for all of these elements, but just to say that, you know, we had a major change to the program in 2017, which was a major opportunity to implement pathology report forms cohesively collecting Indigenous status, and that did not happen. However, there was a obligation for those now that who have reporting obligations that they have to report Indigenous status if known. But obviously, if it's not recorded on the pathology pap test, then it's not going to be transferred. In 2018, of course, we saw the call to action for the elimination, but also Menzies and the VCS Foundation were contracted by the Cancer Australian Department of Health to deliver a project really to overcome those fundamental long-standing issues around data to improve outcomes for Aboriginal and Torres Strait Islander for women and overcome those factors that the programs have failed to do. That report was handed back in 2019 and unfortunately has not been made public. And then I guess we go on to see what's been really an exciting but weird time for some of us, because we see this excitement around eliminating a cancer and we know what's possible, and yet such stark within country inequity. You know, we were not able to model how quickly we can get to elimination for Aboriginal and Torres Strait Islander people because of the paucity of data. However, in 2020, as Ian alluded to, during COVID, I had many calls around people still asking whether pathology report forms don't include Indigenous status, and this had major ramifications for testing. And through that, I know that NACCHO put forward a submission to the Commonwealth that really, we hope, and has made some important changes. So really just to kind of sum up, because that's been a lot, is just to think about Indigenous status in terms of cervical screening participation data. We know that there's been this real reliance on localised studies and research to report on Aboriginal and Torres Strait Islander people's participation in the program. We've had no program performance. We haven't known what works. We don't know what doesn't work. This is a long-standing issue. Many solutions have been put forward by many people working in this space for a long time, and with really almost no progress. Hopefully COVID will be the difference here. And it's really this lack of political will to address pathology report forms. There's been clear evidence with maximum benefit. And just to say that in the previous National Cancer Screening Register report, there's yet to report on Aboriginal and Torres Strait Islander participation nearly 5 years after the renewal of the program, but they have reported that about a third of people in a screening age range do not have complete Indigenous status. They're now linking it to Medicare data to supplement Indigenous status instead of getting it from pathology report forms, but will also take it from pathology if it's available.
Okay, thanks, Lisa. So Lisa's given you a fairly thorough overview of the kind of issues around those first two World Health Organization elimination targets around HPV vaccination and cervical screening. So now I'll take you through just the last one, which is about treating pre-cancer and also treating invasive cancer. So the pre-invasive disease kind of breaks down into this idea of, firstly, you have to be able to do the colposcopy examination of the cervix to ensure that you know, those high-grade abnormalities are actually being investigated appropriately and in a timely manner. So it's actually really critical to actually having a effective screening program, is that you need to have a diagnostic pathway to follow through after that. So our screening program is only as good as the follow-up, I guess. So from some data from one of the big landmark indicator reports just produced just within the last month or so, we found that about 60% of Australian women attend colposcopy within 3 months and about 90% within 15 months, but we don't have any national data available for Aboriginal and Torres Strait Islander women. We do have a small amount of Queensland data suggesting that there are greater barriers to timely colposcopy for Aboriginal and Torres Strait Islander women. We know there's lots of issues around access to health services and making sure that's a culturally safe experience. So this is a key point in this kind of the pipeline where inequity may be perpetuated, and it's something that we're watching really closely to ensure that we can address that appropriately. The second part of the pre-invasive disease thing is actually being able to treat high-grade abnormalities, obviously essential in preventing cervical cancer from becoming invasive. So again, we don't have any routine national data, and we don't have any national data for Aboriginal and Torres Strait Islander women or non-Indigenous women. So there's just a huge question mark over what this looks like. So reporting relies on additional data requests and sufficiently complete reporting and recording of histology and colposcopy data on the National Cancer Screening Register. So clearly this is a really big place where we can be focusing our efforts on the development of optimal data collection and reporting. And finally, for invasive cervical cancer treatment, for those proven cancers, again, we don't have any routine national data for Aboriginal and Torres Strait Islander women or non-Indigenous women. We do have a little snapshot from Queensland data suggesting that at least 92% of women do receive some treatment, but we also know that that treatment is more likely to be suboptimal for Aboriginal and Torres Strait Islander women. So again, there's a lot of question marks here and something that we'll be looking at really closely in the future. We don't know what that care experience looks like for Aboriginal and Torres Strait Islander women. Does a cancer treatment pathway follow both clinically optimal pathways, but also are they culturally safe? What does survivorship look like for Aboriginal and Torres Strait Islander women, and how can we assess this appropriately? So this is clearly an area that we're looking to develop up a bit more, and making sure that we've got the right data collection around it to ensure that we're assessing and monitoring that progress towards elimination. So I guess just starting to wrap up, and I know we've got a little bit over time, but clearly elimination is not on track for Aboriginal and Torres Strait Islander women. Lack of data has been a major contributor to this. We cannot achieve elimination without addressing these racialised health inequities, including the need for accurate and complete Indigenous identification in national data sets. And without this, it's really difficult to actually implement improvements and monitor progress, and ultimately this really stops our ability to make real change in the burden of disease experienced by Aboriginal and Torres Strait Islander women.
Thanks, Tamara. So just to finish up with some final thoughts. So I guess just to be really cognizant that our call for adequate data is not about a hyper-surveillance of Aboriginal and Torres Strait Islander people, but about making sure that these systems are held to account. It's about understanding the system failures, and there have been many, rather than individual blame of people not turning up to screening. And I think it's important for all of us just to remember that more or better evidence doesn't necessarily equate to action or change. It's a false dichotomy, and I think that it's one that's been perpetuated largely in Australia. And of course, that eliminating racism is really critical to achieving equity, and we see it play out in every way in this society. And one way is by not reporting accurately Aboriginal and Torres Strait Islander status within Datasets. It's a real way that of colonial oppression and the way that we've been silenced. So thank you very much for having Tamara and I today, and thanks very much for putting up with my being outside, and I'll hand it back to you, Abby.
Thank you very much, Lisa and Tamara. And thank you for enduring the wind and the cold there, Lisa. Our final speaker today is a self-professed data nerd and epidemiologist, Dr. Clinda Griffiths. Dr. Griffiths is the Science Teacher Lecturer at the Centre for Big Data Research and Health at the University of New South Wales and holds an honorary fellowship at the University of Melbourne and Menzies School of Health Research. Her interest is in empirically addressing complex health disparities in populations through the use of existing data. For this, her research addresses issues of quality and the use of big data collected on Aboriginal and Torres Strait Islander people, with particular focus on Indigenous identification in official reporting, developing Indigenous data governance processes and the measurement of health disparities. Clinda holds a number of national and international leadership roles, including Deputy Editor of the Health Promotion Journal of Australia, Steering Committee member of the Indigenous Data Network, and is a National Health Information Strategy Independent Expert Panellist. Kalinda's talk today is on data governance and Indigenous health measurement and international perspective. Thank you very much, Kalinda.
Thanks, Abby. Can you hear me okay?
Yes, I can.
Yeah. So thanks for the invitation to come and have a chat with you all. It is a privilege to be talking to you about a topic that is close to my heart, but it's also of such importance, which has tangible and life-changing effects, as we've seen from the other speakers here today. And kudos to Abby and the AEA crew for setting up this symposium. Before I begin, I would like to pay my respects to the traditional custodians of the many lands on which we're meeting here today, particularly the Larrakia people on whose sovereign lands Darwin was founded, unceded, where I'm calling from. I would also like to pay my respects to all elders, those of the past, the present and the future. And I'd like to acknowledge other Aboriginal and Torres Strait Islander people and Indigenous peoples here today. So, Nayu Nilawa Kalindabafis, Nilawa Corpus, Nayu Yawu Jandu, Janu Buru Bibi. My name is Kalindabafis, my family name is Corpus, and I am a proud Yawu woman. My country is in Broome in Western Australia. And I guess my interest is in the usability of existing data and big linkage data for the purposes of research, primarily to better understand why some populations are healthier than others, but also to support community development as well. So what I thought we could do here today is a bit of a conceptual talk and contextualise Indigenous data for research and reporting purposes. And I'll highlight some of the critical discussions that are required when we talk about Indigenous peoples and Aboriginal and Torres Strait Islander people in official statistics and data collections, as well as some of the considerations in the data governance within this context as well. And I'm hoping that this will be useful for people in terms of ideas and strategies for research with Indigenous peoples and Indigenous communities into the future. I do want to preface a couple of things before we go on. Firstly, that I use the term disparity in this talk, and I use it purposefully. I use it because it highlights an implicit assumption that the differences we see between populations can be due to social injustices and inequity, and not simply a variation in equivalence between two groups, so an inequality. And this is an important term because it describes these embedded systemic issues in society, as well as those things that we cannot accurately measure, things like the impact of colonisation. I also use the terms Aboriginal and Torres Strait Islander people and Indigenous peoples, and I primarily use the term Indigenous peoples in an international context. Full disclosure, I do really love data, and it is great to be among fellow data nerds here today, but we are in the data era. And I guess data is important for understanding distributions of health and wellbeing within the nation. And whether this is mapping healthcare services, identifying or improving screening outcomes, or utilising community level data to report on community priorities, data plays a massive role in our understandings of health and society. But the picture is expansive and it's dynamic, and data is growing exponentially every day. And while data has this incredible potential, there are a range of considerations and gaps regarding data and data use when we work within the Indigenous context. So in 2019, a group of us published a review on Aboriginal and Torres Strait Islander identification. A few people have spoken today who are on this authorship, and some people are in the audience as well. But we recognise that identification is the central issue in the data collected about Indigenous peoples around the globe. And so this was one of 9 articles from 5 nations discussing the identification of Indigenous peoples in their respective nations. And so the countries included Australia, New Zealand, Canada, the United States, and Brazil, and it arose from a number of global meetings over the past several years with members of the International Group for Indigenous Health Measurement. And it also included people working in official statistics and governments and with international agencies. And importantly, previous meetings on how to best measure Indigenous health, specifically the impact of colonisation upon health, highlighted the known invisibility of Indigenous peoples in official data collections. And the result of this, it actually placed an advocated call to international and national statistical agencies to improve global efforts in the collection of Indigenous data. And so this raised further discussion about how Indigenous peoples are counted and by whom, how human rights are met in regards to the right to be counted as Indigenous peoples, as well as highlighting the quality of the information used to report on Indigenous peoples. We thought it was also important to describe some of the critical issues arising when we discuss Indigenous peoples in official statistics as well. And so there were 3 primary overarching international issues that are also important for Australia to consider. Firstly, who is counted, which includes considerations regarding the definitions of Indigenous peoples and the operationalisation of those definitions, as well as the propensity for people to identify within the data. Secondly, how many people are counted, and this includes issues of the completeness of the coverage and the accuracy of the enumeration, as well as methodologies used by national statistical agencies to address these issues of over and under enumeration. And thirdly, what is counted and measured, which involves the development of indicators and measures that encompass Indigenous peoples' states of events, their values, and their understandings. Before we go any further, I want to have a conversation about the context of Indigenous data, and this conversation is often a challenging one to have, but at its core, it really is better for understanding these issues. And most official data collected by governments on Indigenous peoples is developed within a colonial and racialised context. And what this has resulted in is what we call coloniser-sanctioned forms of recognition. What do I mean by this? Well, while the recognition of identity, so who we are, can be achieved by Indigenous peoples for Indigenous peoples, we need to be cognizant that the recognition of indigeneity within data has historically been granted by governments. So as an example, the Australian government officially counted Aboriginal and Torres Strait Islander people from 1901 until 1967 for the sole purpose of excluding us from the national population count. So in 1967, with the Australian referendum, it resulted in changes to sections 51 and 127 of the Constitution. And it was the change to 127 that resulted in the inclusion of Aboriginal and Torres Strait Islander people in the census. Now, this inclusion only arose from the nation's moral imperative to include and count Aboriginal and Torres Strait Islander people via this democratic vote. And further, it wasn't until 1978 that the Commonwealth definition of Aboriginal and Torres Strait Islander people was developed. And again, still, it wasn't until 1996 that the operationalisation of that definition, the standard Indigenous question, was officially implemented. And so I guess the point is that our starting position with data is within this kind of paternalistic power differential. And basically, we were allowed to be counted. So people have the right to recognition and the right to be counted. And when it comes to data and official statistics, individual and collective rights to citizenship in Australia can only be met with accurate identification and accurate counts in the data collected about us. Recognition is embedded in our right to self-determination, and there are a couple of critical articles within the United Nations Declaration on the Rights of Indigenous Peoples, as well as other human rights mechanisms as well. But these provide a kind of blueprint for nations to discuss and incorporate Indigenous people's rights in the discussion of data and information collection. The first is regarding the right to identify, where Article 33 states that Indigenous peoples have the right to determine their own identity or membership in accordance with their customs and traditions. And look, it's clear that Article 33 highlights the requirement for self-determination and identification. And it should be also noted that it purposefully does not specify a definition of Indigenous peoples. So Article 15 states that Indigenous peoples have the right to dignity and diversity of their cultures, traditions, histories and aspirations, which shall appropriately be reflected in education and public information. So this, along with the right to identify and our right to self-determination, actually provides a framework to guide what information is collected about us and for what purposes. And so in regards to managing these expectations about what happens with that data, Indigenous data governance approaches underpinned by community-led Indigenous data sovereignty principles can be developed in programs and systems that collect information about us within our respective nations. And so Ian Anderson, one of our leading Aboriginal academics, terms this as the democratisation of data. If data is to be used to tell our stories, our experiences, and we're going to be reported on, then we need to be at the table, and we need to be aware that we have every right to do so. So I guess the question is then, how do we reconcile the hegemonic issues with data and the needs and aspirations of Indigenous peoples? Well, I don't have the answers to this, but the starting point is embedded in human rights and Indigenous data sovereignty and governance and the application of those rights. And we need to talk about it a little bit more. Like I said, data can be very powerful. It can be powerful for governments and it can be powerful for Indigenous communities. So what is Indigenous data sovereignty? Well, no doubt you've all heard the term and you're probably hearing it much more frequently these days. But before we define it, this is a timeline that we've developed from a review that we did on Indigenous data sovereignty in Australia. And we found that there were a number of principles, issues and needs specific to Aboriginal and Torres Strait Islander people and data that have been explicitly described since 2004. This timeline is specific to Australia, but although it does include a lot of the international components, I want to point out here that in 2016, the ANU, Australian National Centre for Indigenous Genomics Statute, was enacted as law. This document requires that all samples held as part of a historical research program be overseen by Indigenous governance. And for me, I see this as one of our first feats in self-determination. And if anyone has the chance to see it, I highly recommend that people read it. And so as a quantitative researcher, and having worked in this space for the past 15 years, and I guess applying these practical approaches to this, we've only seen the arrival of the terminology and the discussion of data sovereignty over the past 5 years. And so I want to point out with this timeline that while Indigenous data sovereignty literature and languages has been developing very quickly over the past 5 years, for those of us who have worked within large population level data assets, we've been having these discussions for much longer than this. And so Indigenous data sovereignty has been defined by Kukutai and Taylor as the inherent and inalienable rights and interests of Indigenous peoples relating to the collection, ownership and application of data and information about their people, their lifeways and their territories. And we all know now that when we work with data, there is a complex array of factors across multiple sectors that contribute to data collection and reporting. And Indigenous data sovereignty is the way to assert self-determination in the way in which we develop, control, maintain, protect and use our data. It should be noted, however, that Indigenous data sovereignty is a conceptual term and it is theoretical by default, but it is applied to Indigenous data governance processes. So if Indigenous data sovereignty generally is about managing information and data in the way that's consistent with laws, practices and customs of the nation state in which it's located, then where do these inherent and inalienable rights and interests of Indigenous peoples fit? Well, I guess the power differential that I spoke about earlier has resulted in limited structures that support Indigenous worldviews, values and understandings in societies generally. So for me, I see now that the time is for valorisation. That is normalising value and supporting Indigenous worldviews, practices and understandings within Western structures, legal and regulatory frameworks as well, that will facilitate ensuring the rights and interests of Indigenous peoples are met. So basically, Indigenous data governance that provides for collective representation of the needs of individuals and their communities. So data is incredibly important in regards to the reporting and the provision of services for our mob. And so data is used to describe and monitor the social, economic and health and wellbeing of Aboriginal and Torres Strait Islander people. And this reporting occurs internationally, nationally, across state and territory jurisdictions. It also occurs at the community level as well. And so data and the information derived from data about us matters. In fact, in Australia, data mattered so much that the Commonwealth's Bureau of Census and Statistics, which is now the Australian Bureau of Statistics, and its subsequent Legislation Act was developed less than 5 years after Federation. This meant that the federal government prioritised the collection of data and information through the development of an independent regulatory body. We know then that data holds power, and data matters because it tells us who needs what where. But it matters differently to different people. For me, it matters because if we aren't counted in the data, then we effectively don't exist. Our official reporting includes meeting requirements on existing agreements with the OECD and the United Nations. We've got the National Indigenous Reform Agreement and the new National Agreement on Closing the Gap, which includes the Closing the Gap targets, as well as a range of state and territory policies and frameworks. But the enumeration, the counts of Aboriginal and Torres Strait Islander people isn't just necessary for reporting. It's also necessary for the allocation of population level funding and individual services. So for example, the Commonwealth Grants Commission, which allocates goods and services tax, uses measures of population growth, including intercentral differences based on ABS estimates of populations to allocate funds across regions. So this table here shows that there was a 14% difference from the 2011 to 2016 censuses, the impact of which we're yet to learn more about. But if history repeats itself, then this could mean that outer regional and remote areas may miss out on funding. And this has happened in the past. And further, the Australian government requires that Aboriginal and Torres Strait Islander people identify themselves as such to receive Aboriginal and Torres Strait Islander specific services and programs. And I guess that this is all overarched by the fact that Aboriginal or Indigenous peoples have the right to be counted. So data plays an important role because, again, Indigenous peoples have this health, economic, social, environmental and cultural rights that cannot be wholly addressed if there's missing information and large inaccuracies in the reporting. So this is a graph that shows the differences in mortality rates between Aboriginal and Torres Strait Islander people and non-Aboriginal people from the 2020 Closing the Gap report. The report commentary to this graph states that there is a significant decline in mortality rates from 2006. Now, this data trend statement is a concern because it relies on the initial years of decline from 2006 to 2009. Everyone who has ever played with Aboriginal and Torres Strait Islander data knows that the quality of mortality data has quite a few issues up until about 2010. My point is this: methods matter. If we think about this in absolute terms, then the gap isn't closing. In fact, it appears to be getting wider from this graph. And we kind of need a reality check when it comes to reporting processes. And if there are disparities, then so be it. It means that we work towards solutions instead of denying that the issue exists or trying to reframe it. I also want to note that in the 2021 Closing the Gap report, age standardised mortality rates were not presented. Instead, a comment on child and infant mortality rates, as well as a graph on age standardised avoidable mortality rates were shown. Just some food for thought then. So as a quick example of issues with the undercounts, this is the birth registration example. So Aboriginal and Torres Strait Islander births within a number of states and territories are critically underreported. We know that there are a large number of births missing from official statistics used for reporting purposes. And so to identify the issue of birth registration underestimation, 2 data sets are typically used. The first one is the perinatal data collection, which holds information about obstetrics, delivery, perinatal outcomes, and the data is collected in each state and territory from midwives and other staff who use information collected from mothers and from hospital records. The second is from birth registrations data collection, which is the information given to state and territory registries of births, deaths and marriages, usually by the parents after birth. The data captured by registries can vary by state and territory, which can also impact its consistency. Nationally, we know that there is almost 5% under registration of births when linked to the perinatal data collection. However, when this is looked at by Aboriginal status, rates increase to 17% and 18% under registration in Queensland and Western Australia, respectively. Further, if this is looked at by remoteness, the proportion of under registration by Aboriginal and Torres Strait Islander babies in remote and very remote areas is up to 23.4% and 27% for Queensland and Western Australia again. So these estimates of under registration show that 1 out of every 4 Aboriginal and Torres Strait Islander babies and babies born in remote and very remote areas don't exist. What does this mean? It means that anyone using birth registrations for the purposes of official statistics reporting would actually get it wrong. It's also why there have been different statistical methods used when Aboriginal and Torres Strait Islander birth registration data should be used for things like life expectancy estimates, as Ian mentioned. It basically complicates things more through things like backcasting and enhancing life expectancy estimates through census data. What do we do about it? Well, birth registrations enable the rights of citizenship to be enacted. Everything from a Medicare card to a passport is the result of having our birth registered. This requires working with registrars in states and territory jurisdictions to ensure that all of our babies are counted. In terms of official statistics, the good news is that the move towards data sharing within governments will enable us to pick up those people who access services through data linkage. So as an example, a baby may not be registered at birth, but may be picked up by a GP or education within the education system. This data could theoretically then be used to enhance birth registration data and flag those people who require registration to ensure birth certification. But it isn't just about handing over information about us. This is about ensuring governments and official statistic agencies can actually work for us. There is a real potential to use, I guess, Indigenous data governance in reforming systems to drive Indigenous agendas. When it comes to data for real change, having Indigenous leadership and community identified priorities, needs and aspirations, as well as strategic partnerships, I think can assist in the way forward. The work of the Indigenous Data Network reflects this, and there have been a few research programs that have been doing this. And so I guess a successful example of the power of using data to prioritise our needs, the work arising from the broad international and national partnerships through Menzies, headed by Gail Garvey and Joan Cunningham. This has resulted in implementing policy changes that aim to improve national services and systems for Aboriginal and Torres Strait Islander people with cancer. So when I first started in cancer epidemiology a little over 10 years ago, we didn't even have national estimates of cancer for Aboriginal and Torres Strait Islander people. An important gap in the data of our now biggest killer. The first semi-national estimates for Aboriginal and Torres Strait Islander people were done back in 2010. And now there's ongoing national reporting, as well as a national framework to tackle cancer. And we can use data to monitor the impact of these implementations and progress into the future. However, there is quite varied differences as to whether data is being used for the priorities of governments, research, or for the priorities of Indigenous communities. The question here is, Who speaks on behalf of whom when it comes to data development and our use? So just pulling together some of the things that I've mentioned here today, we'll conceptualise through this diagram. The recognition of Indigenous peoples require the acknowledgement of Indigenous peoples, and also includes how Indigenous peoples are described and defined. This should be in alignment with the UN Declaration of the Rights of Indigenous Peoples. And while Australia does quite well relative to other nations in regards to data capture and recognition within systems, this is about systems and data supporting our right to self-determination and community advancement, which in Australia needs much more improvement. We also need to talk about operations. How do we best build data assets that reflect the aspirations of Aboriginal and Torres Strait Islander people and the capabilities of the next generation of Indigenous data nerds? I guess some of the work that we're doing within the National Indigenous Data Network is about developing community-controlled data assets and building the technical capability of communities alongside in partnership with governments. We also need to recognise who are setting the priorities regarding data use to benefit the aspirations of Aboriginal and Torres Strait Islander people and communities. We always need to be asking the question, who are the we in this discussion when it comes to population level data and decision making? Who should be representing whom? I don't have the answer to these questions, but some of the work that we're currently doing will hopefully find the best ways of doing this into the future. And finally, we need to work on and focus on monitoring. How are we actually doing? Where should we be focusing our resources? Again, it's dependent on who's doing the monitoring and where that information goes. This determines the narrative, the stories that are being told about us. So it is important that we're leading it. In order to answer some of these questions arising from these discussions and to develop an integrative framework that can capture some of these issues, I am leading a collaborative program that will systematically develop national best practice evidence-based recommendations for the use of Aboriginal and Torres Strait Islander data. So if anyone is interested to speak more about it, I'm happy to have a chat at another time. But I did want to finish by noting that this talk is specific to administrative data, and that is my favourite type of data. And it is data that is overseen by regulatory bodies, legal frameworks and existing governance processes. What I haven't discussed here is digital data, metadata or AI potential. Although I guess similar considerations have been raised here will actually apply. It is worth noting though that there are limited regulatory and legal frameworks regarding these data in Australia. And this raises further challenges in asserting data rights, particularly for Aboriginal and Torres Strait Islander peoples. And I want to plant the seed to grow towards building capabilities in these sectors for anyone exploring this. But to me, I see the challenges in data use as complex. It's multifaceted, it's dynamic. And I think we need to be like water. We need to be adaptable to the changes in the data landscape as they may arise. And I think some of the answers lie in directing the conversation towards evidence-based Indigenous data governance. It should be underpinned by community-led Indigenous data sovereignty. And this should ensure that there are mechanisms of voice for Indigenous peoples and community in regards to how our data is collected and used. We also need to recognise the work from previous Aboriginal and Torres Strait Islander leaders in fighting for our rights to be counted in the data. We cannot diminish this at all. And that if we aren't counted, then we effectively don't exist in the eyes of government or within existing systems. Undertaking system reform in data, I guess, is about requiring us to bust open all of the silos, work within an Indigenous governance process, and face some of those uncomfortable truths that we've mentioned here today, and work together. But I'll finish up there, Abby, and just my acknowledgements.
Thank you so much, Kalinda. That was a extremely interesting and engaging talk. And I just want to say that on Twitter we had Charlotte from the US staying up very late to listen to you, and she says she thinks you two are twins with your data nerd happening. So thank you to all the speakers. Thank you to Ian, Professor Ian Ring, to Dr. Mandy Chong and Dr. Jocelyn Chan, Dr. Tamara Butler and Associate Professor Lisa Wap and Dr. Clinda Griffiths. We now have a Q&A. Please put your questions into the chat window and I'll try and get through them. We have about just under 20 minutes to have a quick chat, so we should get through a few questions. I will start off with one of my own, which kind of leads on from Clinda's discussion, but it also came up when Lisa was talking. So I'd like to put this question to Lisa first, but then Clinda, you might like to jump in. So Lisa, you said that we are calling for adequate data, and this is not about hyper-surveillance, it's about system accountability. Do you think that there is a need for better public education around the collection of Aboriginal and Torres Strait Islander identification data, and also data for culturally and linguistically diverse populations? And the second question is, how can this be done within a data governance and data sovereignty framework?
Thanks, Abby. And I'm back in the safety of my office now, not freezing outside. Although Canberrans tell me this is very mild for them, it's not. It's a really good question. I don't know, I can't speak necessarily culturally and linguistically diverse data collection, but I mean, in terms of Aboriginal and Torres Strait Islander status, I think if you're an epidemiologist or a public health professional and you're working in the space that collects data, it's really your obligation to know about and do the work. You know, it's not really up to people like Clinda and I and others to give you the manual of exactly how to do it. You have to know why it's important. You have to understand the colonial way in which this country operates. So I think that public education could be good, but I think it has to be a balance between that then being put onto the workload of Aboriginal and Torres Strait Islander academics or people working in this space. So I'm always conscious of making sure that I state that, because I think what happens is the solutions then are always put back onto Aboriginal and Torres Strait Islander people to fix this. And in terms, I guess, of that hyper-surveillance, I think that it's just this inherent way in which we think that we're constantly trying to, it just feeds into this narrative around the dying race. I mean, we talk about indigeneity all the time as a risk factor. We see it in the Close the Gap report every year. And yet we really fail to understand and discuss in detail about the real violence of these systems in the way that not only they fail to count us, but the way they fail to care for us. So we see that, you know, on today, like in extraordinary ways. So I think public education, of course, people have to know what they know, I realise, but I think that we have come to a point in time that there's enough out there to do a bit more work yourself, and perhaps in the way that we teach this stuff, because I know, at least when I trained as an epidemiologist, none of the sort of things that I think about on a daily basis or the yarns that I have with Clinda and others were ever discussed in the classrooms that I learned in. So I'm sure Clinda probably has some really good answers to around governance as well. So I guess that's my answer / rant.
I agree completely, Lisa. I also think that there is a requirement for anyone who's collecting information, so for governments, etc., to make sure that there are mechanisms of governance processes involved for Aboriginal and Torres Strait Islander peoples. And this has been, you know, like Ngatsihib was the first, that Ian spoke about, was the first ever to kind of enable a voice around priority setting for national Indigenous data use. You know, the challenge in that, though, is that that isn't embedded within systems. So it meant that Ngatsihib could get cancelled at any point in time, which it did, mind you. It did get made defunct, and it has been replaced since. And Ian and I are both on that group, but again, it can be cancelled at any time. So there's no ingrained processes, and I think that this brings the question mark around a voice to government. It's a broader issue around recognition and making sure that we are able to have a continuous, ongoing voice within the systems which govern us. Ian, you might have something to say on that as well.
Yes, thanks, Kalinda. Look, it is important to recognise that that body, Ngati Head, was kind of roadkill of a move by the Commonwealth to reduce committees. So they abolished it, just like that. What is left is separate advisory bodies to ABS and AIHW, but to my knowledge, there is no adequate replacement. Kalinda's absolutely right. These things can be abolished at the drop of a hat without any thought, without any replacement. But in the end, to get anywhere, I mean, it's always been my view that governments need to govern for everyone in the population. And the real effort has been to try and get governments to discharge their responsibilities in data, in health, and in other social and, I guess, justice areas to Aboriginal and Torres Strait Islander people. That's a long and ongoing kind of process. But as far as data is concerned, there needs to be a table where, with proper governance arrangements, Aboriginal people can sit down with the agencies that do have responsibility and chart a course for the future, and that body was just abolished overnight without any thought.
Yeah.
Thank you. I might put the next question to Mandy and Jocelyn first. This is from, I hope I'm pronouncing your name right, it's a question from Belenu from the University of Queensland. He asks, what are health department and health agencies' views on data sharing for data that contains religion or ethnicity variables for data linkage-based researchers? Is there a, are there specific ethics consideration for this? And also, I'll just add in, someone else has asked whether there's mechanisms to ensure that if data on race or ethnicity is shared with researchers, is there mechanisms to prevent this from being used in ways that weren't initially intended or stated up front?
Thanks, Abby. I'll have a stab. I think, there are ethical considerations for any type of data that's being collected, especially who's collecting it and why. Researchers aren't neutral in any shape or form, so it's really about I think we all need to be transparent about why we're measuring it, for whom and for what purpose. I'm not sure about health. I've not worked for a government health department before, so I'm not really sure what the perspectives about that are, but I think if they are collecting the data, that kind of data, I think they should make it easier for people to access it, especially the communities and the groups that the data is coming from. So yeah, I think it is definitely an ethical consideration.
Did you want to add to that, Jocelyn?
I'll just add that I completely agree with Mandy, and I think maybe this relates to the previous discussion our other speakers were talking about the need for clear governance on who should be making these decisions and based on what, I guess, theory or context.
Great. Did any of the other panel members want to add to that question?
Can I just note that this comes back to, I guess, the basis around democracy. Data is an asset, and if Australia is guided by democratic processes, then I think that we need to embed democratic systems for the utilisation of information. And that should be across the board for all populations. For Aboriginal and Torres Strait Islander people, this has other connotations to it, but yeah, I just want to note that.
Yes, and currently there are specific ethics committees, at least for Aboriginal and Torres Strait Islander health research, to go through an extra check to make sure that it's being used for appropriate and acceptable reasons. Tamara, I have a question for you. I really like the slide that showed all the different countries and how you had plotted, what I think it was in the paper that was published this year, had plotted the cervical cancer incidence for different Indigenous populations. So it looked like Australia and New Zealand now at least had good information on cervical cancer incidence. Do you think that has led to political will to enact action? And do you think in the countries where it's still unclear, there is evidence of a lack of political will to prioritise cervical cancer control for Indigenous women?
Yeah, that's a good question, Abby, and I kind of have a bit of a wry smile about that, because apparently not. Like, you can plot all this information and, you know, there's still just people yelling about how we're going to achieve elimination, and, you know, me and Lisa and others working in the space are obviously just still yelling about, well, it's not going to include all women. So yeah, clearly there's still a lot of work to be done. I'm not sure that I can speak much to the other countries, but I know that at least I might be able to add something here. But yeah, in our view, there's still a lot of work to be done about closing that gap and ensuring that all women are included in elimination.
Yes, I can add a bit more. I think, you know, we should say that while we are the ones still jumping around, I do think that there has been a shift. A few weeks ago, we had the Preventing Cervical Cancer conference, and really the whole theme, the whole morning was all about equity. And I think it's safe to say 10 years ago, possibly even 5 years ago, that would absolutely not have occurred. I think Gail's on the phone, and Joan and others would agree with me there. That it's really great to see this sort of focus now on addressing inequities, but I have to say that at the moment that's purely coming from researchers and academics and the health sector, Aboriginal and Torres Strait Islander health sector, versus that coming from the Commonwealth, at least in my experience, although I think hopefully there's going to be a bit of a shift. And in terms of other countries, you know, we work closely with Professor Bev Lawton in Aotearoa, New Zealand, and they recently have had a member of their parliament being diagnosed with cervical screening. New Zealand are still using, they're not using the HPV test, so they're still using pap smears, and they've been able to demonstrate clearly the evidence that shows that self-collection and HPV-based testing is far superior and meets the needs better of Māori women there who are under and never screened. So I think that there is the work, and there's always the champions within countries doing, you know, jumping up and down. But in terms of political will, I guess I'm always the skeptic in that. And I can see, so he might.
Ian, would you like to add to that?
Yeah, look, Australia has been the home of resource-free policies. You know, you set targets and indicators and you do nothing to achieve them, and you just hope that somehow or other, without doing anything, next year's numbers will look better. Well, that doesn't work. Change is possible, and rapid and sizable change is possible, but you have to do things to bring about that change. I mean, you would have thought that it's pretty clear, I think, from the slide that I showed and Tamara showed, that things are more or less flatlined in terms of mortality over the last decade. You would have thought this would have set off alarm signals. In 10 years, we haven't gone anywhere. The gap, if anything, may be widening. You know, why is that? What should we be doing? Not a ripple, not a ripple. So that's why I put up that policy cycle at the end of my sort of little talk, that information of itself rarely produces anything unless someone grabs hold of it. Like Kelvin Kong, for example, grabbed hold of the ear data and he mobilised the AMA and talked to the minister, got somewhere. And others have done the same. You have to kind of get that political voice, but simply assuming that data by itself will spur people to action, it just ain't like that. But So that's why you have to sort of create a climate which calls out for change. And so it's hard, but it is possible, and we need to do it much better. The new plan that's come out is resource-free. And, you know, maybe this time magic will happen, but don't hold your breath.
Just to add to that too, Ian, I really liked your line there about the mistaken belief that indicator reports themselves will make action happen. Like, I think particularly in the case of cervical cancer, we know enough and that it's really time for action now. So kind of we're just, I know, moving forward with kind of implementing things to get some you know, shift in that burden of disease for Aboriginal and Torres Strait Islander women. So, you know, it's not challenging that idea of sort of describing too much when actually we know enough to know that something needs to be done and moving to that step.
That's a really good point. Now, another question, I think we've got time for at least one more. I'm going to combine two actually from the audience, sorry, from the participants. Should there be a minimum data set for all researchers to collect? And someone else asked, and I think, Mandy, you might be best to address this because Jocelyn did refer to your study. Do we need to measure ethnicity or culturally and linguistically diverse groups insert or their identification in certain ways? Like, do we need to collect multiple variables such as language spoken at home, country of birth, ethnicity, and then if you have multiple variables, how is that then analysed? Which is probably too long to answer right now, but if you can add something to that.
Yes, that's a really good point. How do we measure cold data? Well, I think it has to be multiple variables. We have to look at things like country of birth, language, generation status, migration factors, acculturation time in Australia. And I'm not a quantitative researcher, so I can't point to any particular methods because the study we were involved in was quite challenging when people were able to pick multiple ethnicities, but how do you put that in a statistical model? So I think we just need to come up with more sophisticated models or statistical analysis, don't we? Because you really lose that nuance when you're trying to group a heterogeneous group of people into one or two categories. You just miss out on so much information if you're grouping people from Middle Eastern backgrounds with Africa and, you know, all that. So you just, yeah, you're obviously going to get the wrong answer to your question if you kind of use that approach. So I think we need to pay more attention to it. And when we use these categories, we need to be transparent about what we mean because they are defined differently in different jurisdictions, in different research disciplines. So I think we need to make more effort to explain what we're doing, justifying why we're taking that approach and the limitations of existing methods and maybe try and find new ones. Also, I want to quickly pick up on what Tamara said and Ian about I think we need to move towards implementation science because there's so much that we describe ad nauseum that we really need to get some courage and go out there, implement some policies and work out what works and what doesn't work. Be honest about it and try and move forward to really address health inequity.
Do you want to add anything to that, Jocelyn?
Yeah. So I agree entirely with Mandy about the need to collect different variables and to really think about the research question when you're designing what sort of questions you can ask, because it is important to capture all these different facets. And I thought I might just quickly touch on the question about the minimum data set, because I can understand the pros and cons for such a move, in that like having a minimum data set can mainstream the collection of such called data, but also it might mean that people don't really think about why they're collecting this data and what exact variables you need to answer your specific question. So,
thank you. I think we're out of time, but I just want to say the last question that just came through, I think needs to be the title of our next AEA symposium. How do we as epidemiologists make action happen with the data we collect and analyse? So we don't have time to discuss it now, but great question and maybe another panel discussion in the near future. I just want to thank all the speakers again and thank everyone who's attending. Members, AEA members, the recording will be available soon. A link will be in the bulletin. And have a good day. Thank you.
Thanks, everyone.
Thanks, everyone.
Thank you. Thanks for hosting.
Thanks, Abby.
Everyone.